Welcome to this first video on the subject sleep and its disorders. This is the first video on a series about this topic. I'm producing content about subjects in medical school in general, but I'm currently also working in a sleep lab and would like to share an overview of sleep and its disorders with you. We will discuss sleep in general and its physiology today. We also mention some aspects of polysomnography and EEG findings during the night, but will go in the future in further detail. You will find questions and answers that guide you through the video for active recall in the description down below. Let's start. What defines sleep in general? Sleep is a relative suspension of consciousness while the voluntary muscles are inactivated. We're talking about relative suspension because one could argue that dreaming, and especially so-called lucid dreaming, and feeling sensations during the night can be understood as some kind of consciousness. Sleep is regulated by two internal systems that tell you when to sleep and when to get up. You can imagine them as an inner clock and a coal-fired power station. Just remember the inner clock as a circadian rhythm and the coal-fired power station as homeostatic drive. The circadian rhythm regulates the timing of the sleep-wake cycle like an inner clock. It is genetically controlled and different from person to person. There are also some other aspects that influence it, such as your age, external cues like light exposure and social activity, but in general, you're determined by factors you can't influence. Many simple explanations say the circadian rhythm would be 24 hours long, but that's actually not completely correct. According to Westermann, it is 24.16 hours long. I find it amazing that evolution has come up with an inner rhythm that takes our planetary movement around the sun and the evolving length of days into account. Nevertheless, the circadian rhythm gets synchronized with the sun in any case by the external cues. The circadian rhythm influences then more than just our sleep. Our body temperature, hunger, and many of our hormones are also coordinated by it. If you imagine the circadian rhythm as the inner clock of your body, you can think of the homeostatic drive as a coal-fired power station in terms of sleep. The coal is in our example the adenosine triphosphate that gets converted to adenosine monophosphate. This builds up in the basal forebrain and progressively promotes sleep. The storage of adenosine triphosphate gets refreshed, so in our example, the power station gets fresh coal during sleep and can burn again. Ideally, the circadian rhythm and the homeostatic sleep drive are in perfect alignment. That would mean that you get up when your circadian rhythm tells you to do so and be active enough to let enough adenosine accumulate in your basal forebrain before you go to sleep again. Due to many reasons, such as artificial light exposure through the screens of our devices and alternative sleep-wake patterns, these rhythms are in misalignment in many people. Now, once we've got some insight into what sleep means and how the body introduces it, we can talk about the process of sleeping itself. Although the vast majority of people might not notice, we go through several sleep cycles that consist of 4 different sleep phases each night. A sleep cycle is a period of 90 to 120 minutes, and depending on the duration of your sleep, you have 4 to 5 each night. These sleep cycles are pretty similar overall. We will explain the slight differences in their phases once we've understood them. One sleep cycle goes through 4 different sleep phases. You can see them in the diagram. As you can see on it, we go from the waking state through the Rem sleep without remaining there and enter N1 within 10 to 20 minutes after lights out. Rem stands for rapid eye movement. We'll explain later why it's called like that. N1 stands for non-rapid eye movement 1. This is the lightest state of sleep. Then we go through sleep phase N2 and N3 and leave N3 to go back to N1 and Rem at the end of the first sleep cycle. Now, with having seen that, we will walk through each phase, each stage of sleep, and have a look at their characteristics. I'll draw some of the polysomnography findings to make it more visible. Polysomnography is a multi-parametric diagnosis tool in sleep medicine and a technology I'm using with every patient in the sleep lab. There are some specific adjustments from patient to patient and also from sleep lab to sleep lab, but most parameters are pretty much the same everywhere where sleep and its disorders get examined. We will go into further detail on the specific characteristics of the amplitudes in the EEG and some other categories in the next video. We also won't talk about disorders yet. Let's understand the basic sleep, the sleep you hopefully enjoy first. Firstly, we will introduce a classic polysomnography screen. You can see the EOG at the top of the screen. EOG stands for electrooculography. Electrooculography is a technique for measuring eye movements. If you start an electrooculographic measurement, you place 2 electrodes on your patient's face, one below or above the side of each eye, something like this. The EOG measures the corneoretinal standing potential that exists between the front and the back of your eyes, or our eyes in general. If the eye moves from a center position toward one of the 2 electrodes, the other electrode faces the negative side of the retina. Movements towards an electrode create positive voltage, whereas movement away from an electrode creates a negative voltage. To put it in a nutshell, if you've placed the electrodes right and there's no other technical trouble, you will see anti-parallel graphs. Below that, you have the EEG. We won't go into detail in terms of the locations of each electrode that is typically installed for polysomnography in this video. The next video on sleep will be entirely dedicated to that. Therefore, for simplicity's sake, and because the graphs of the EEG are usually pretty parallel during the polysomnography, we will just draw one graph for the EEG. But please be aware of that simplification and don't expect to see one single row for the EEG when you look at the results or an ongoing polysomnography. The ECG is always a part of the polysomnography, but we leave that out because there are not a lot of exciting things going on during a routine night's sleep. You can just be aware of the fact that heart beats lower while the patient is sleeping, and that events such as dreams can have an influence on that. We will not discuss the disorders in which the heart does other things than that in this video. Then we usually have 3 graphs for EMGs. EMG means electromyograph, and the result of its recording is an electromyogram. EMGs detect the electrical activity produced by skeletal muscles. We usually have a chin EMG and a leg EMG. The chin EMG has 3 electrodes around the mouth and tells us in the monitoring room about the movements of the patient's muscles that are associated with chewing and other activities of the mouth. This can be, for example, interesting to detect bruxism, a condition in which people grind their teeth excessively during N2. It is also a good indicator of sleep phases. There is no chin EMG activity during REM sleep at all, but we will get to all these details soon. The leg EMG has 2 electrodes at each leg to detect leg movements during the night. This can be interesting, for example, to detect restless leg syndrome. Then we have some other graphs for snoring, PT flow, thorax, abdomen, oxygenation, pulse, position, and also pressure in case we adjust a mask. We won't discuss all these graphs today, and will go into detail when we talk about sleep apnea and other disorders that affect the breathing process. This was our brief introduction to the design of polysomnography. We'll walk through the different sleep phases, and I'm sure the meaning of the graphs will become clearer while we're doing that. If we start our journey through the kingdom of sleep in the condition you're hopefully right now in, that when the patient is awake and has open eyes, we'll see a lot of anti-parallel graphs on the EOG, especially if he or she observes surrounding objects. If we have a look at the EEG, we see a lot of activity, so-called beta waves with an amplitude of more than 13 Hz. This drawing is not calculated, so don't care too much about this shaky line. All it is supposed to tell you for this purpose is that there is a lot of up and down. If you compare that to our other EEG findings later, we will recognize a significant difference between the ups and downs of the graphs. The level of consciousness is high. Our patient is aware of his surroundings. The chin EMG and the leg EMGs will show amplitudes if the patient is willing to move. The next logical step towards sleep is the closing of the eyes. The patient is still awake, but his awareness of his environment is already significantly decreased. We won't see as many movements on the EOG as we did when the patient had his eyes open. It is important, though, that we keep in mind that the EOG shows the same results with open eyes as with closed ones. It is just the case that patients move their eyes usually less once they're closed. We can see an increasingly relaxed EEG. That means in a nutshell that there are fewer ups and downs on the EEG. To put it in a bit clearer, there are predominantly alpha waves on that stage, which is not a real sleep phase yet because the patient is still awake. These alpha waves have a rate of about 8 to 13 Hz. The chin EMG and the leg EMGs will still show amplitudes if the patient is willing to move, although that level of control fades out the closer he or she comes to N1. We go through REM sleep on our hypnogram, but the first REM episode occurs about 70 minutes after falling asleep. Therefore, we'll discuss it after N3. As you can see, the first phase we spend time in is N1. Our patient sleeps during that phase, but it would be rather easy to wake him or her up. It is therefore the lightest sleep phase. It lasts for about 5 to 10% of the sleep time, and you might remember waking up from it in case you've ever experienced hypnic jerks. Hypnic jerks are the strange moments when when we in general have a sudden feeling of falling or twitching in combination with myoclonic contractions. These are the unprecedented contractions of your muscles when you think you're falling down. Most people have had an experience like that at some point in their life when they were falling asleep. The EEG is more relaxed in that phase of sleep. It has theta waves predominantly with an amplitude of 4 to 7 Hz. So the graph is even clearer than when somebody's eyes are closed. It is important to be aware of the blurred lines between the phases. Of course, there are some clear criteria such as a relaxed chin EMG during REM sleep, but especially the amplitudes of the EEG are often not entirely clear indicators. You might see some sleep spindles during N1, but there is also some literature that will tell you sleep spindles occur only during N2. Sleep spindles are a common finding on the EEG during N2, and we will go into detail in a moment. But let me introduce N2 in general first. The sleep during N2 is already deeper than in N1, and the waking threshold is way higher. It lasts for about 45 to 55 minutes of a sleep cycle. Whenever I tell you something about the length of a phase, in particular if you need to be aware that it also depends on your age and some other factors. We will talk more about that in the future, but you can already keep in mind that these are estimates that highly depend on the individual. The waves of N2 are basically the same as the waves in N1. There are also theta waves, but have a lower amplitude of 4 to 7 Hz. And then there are these two special findings on the EEG during N2. I've already mentioned one of them, the sleep spindles. They look about something like that. And they are an indicator for N2, although you might also see some during N1. There is another special finding on the EEG during N2, and that is called K-complex. A K-complex is a suddenly rising amplitude in the midst of your theta waves. K-complexes can be so strong that they even have an influence on the EOG. This can also be the case with the delta waves, and we discuss in the next sleep phase. I remember that night when I was fairly new in the sleep lab and noticed at around 3 a.m. That the EOG graphs stopped to be anti-parallel. They did the same, they were parallel. I was shocked by these graphs because I thought I would have placed an electrode at the wrong spot or even messed the order of the cables up. If you monitor somebody in the sleep lab, you have several patients, so you can't be totally aware of every single graph all the time. But in this case, the diagnosis was already running for a couple of hours and I was sure the EOG looked different earlier in the night, and it would have been a problem if I would have noticed the mistake at that point. Then a colleague of me explained that delta waves and strong K-complexes can radiate in the EOG findings because its electrodes are so close to the brain. Since then, I'm relaxed when the EOG is parallel during the right phases of sleep. Now we come to the deepest stage of sleep. As you can see on our hypnogram, we arrive there after about 40 minutes of sleeping and remain there for the longest period of time during the whole night. The waking threshold is the highest during N3, especially in the first sleep cycle. The N3 phase is important for physiological recovery and becomes shorter and shorter the longer we sleep. The REM phase, which will be discussed next, is more important for psychological rest, and the body prioritizes its physical recovery first. This is seen from an evolutionary point of view, not too surprising. Malfunctioning bodies are a greater risk to survival than malfunctioning psyches. At least in the short term, that's what's important for evolution. Not getting eaten by a tiger before you've had sex. N3 is not just decreasing from sleep cycle to sleep cycle, its length also decreases with age. Therefore is the estimate of the length in the literature not too precise. We spend approximately 10 to 25% of our night in N3. Typical findings on the EEG are the so-called delta waves with 0 to 4 Hz. Delta waves are by far the most stretched waves you can see on the EEG during the night. If your patient is drunk or takes drugs such as benzodiazepines, barbiturates, tricyclic antidepressants, or Mayo inhibitors, you will probably see reduced delta wave sleep or no delta wave sleep at all. As I've mentioned before, the EOG might be affected by the strong delta waves. Now when we follow along our hypnogram, we see that we leave N3 at some point and get after a short rest on N2 to our first episode of Rem sleep. It will be the shortest period of REM for the whole night unless we interrupt the patients to sleep at some point. This could be a bit difficult though, because it's hard to wake somebody up during the REM sleep. The waking threshold is not as high as it is during N3, but still stronger than in the other sleep phases. It is the prominent phase of dreaming and lasts for about 18 to 25% of the sleep. Its duration and proportion in relation to N1 to 3 increases overnight, but its general duration and proportion decreases with age. So to summarize the significant changes in sleep phase duration, N3 decreases during the night and also with age. REM increases over the night but decreases with age as well. If you sit in the monitoring room of a sleep lab, you might misinterpret REM sleep as a waking period. This is due to the mixed EEG pattern that includes all kinds of waves but predominantly beta waves. There are some characteristics, though, that we will walk through that will make this clear. REM stands for rapid eye movement, and therefore it's not unexpected to notice movements of the eyes on the EOG. A term that you might encounter in that context is REM density. REM density means the frequency of rapid eye movements in a REM period. These eye movements will be visible as an antiparallel graph on the EOG as you saw them when your patient was awake and when you calibrated the EOG and he or she was looking around. But there are not permanent eye movements during REM sleep. They occur from time to time, so don't be confused if they stop for a moment. The EMG shows another characteristic aspect. The muscles around the mouth and chin are totally relaxed during REM sleep. So to recognize REM sleep, watch out for a mixed EEG, some movements on the EOG, and no amplitudes on the EMG at all. REM sleep might be reduced by the same drugs that reduce the time spent in N3, and especially the drugs that reduce delta waves. This was our short introduction to sleep, its phases, and a crash course for some aspects of polysomnography. Because active recall is the best strategy to comprehend and to memorize information, I've provided questions and their answers on a Notion page for you. The link is down below in the video description. It is also my personal learning strategy to ask myself these questions again and again until I know the answers. It is without any advertisements or any costs. I just want to facilitate studying for you. Well, I'm sure you already know how YouTube works, therefore I won't give an explanation on subscriptions, bells and likes. Feel free to do what you'd like to do. Have a great learning experience.